Today I am going to discuss about how to surviving from sepsis. Before 1928, we have to fight with the pathogen by using our own immune system and some herbal medicine. In 1928, Alexander Fleming discovered penicillin. After that, several antibiotics was discovered, several antifungal agents discovered, several antiviral agent and helminth also discovered. Previously, in the past, pathogen attacked by using their heavy weapon time to time. Plague, various kind of flu including the Spanish flu, Ebola. Not the past, the present, they are trying to kill us using their one of the heavy weapon called coronavirus. How much of winning prediction for coronavirus and Homo sapiens sapiens? It is approximately, I think, winning prediction right now high towards the coronavirus, not towards the Homo sapiens sapiens. One of the unfortunate and sad thing regarding the Homo sapiens sapiens side is, for the last 10 years we couldn't make such an important different antibiotic against the pathogen. So, but we are still happy. Why is that? Even though we couldn't able to identify the important antibiotic, we did some investigation regarding the molecular structure of the pathogenesis mechanism in the sepsis. We found to have pathogen is not the one going to damage lot of to the Homo sapiens sapiens. Their own immune system is the one responsible for large amount of tissue damage. Because of that, we are a little bit happy. We try to modify our own immune system. In addition to that, we try to maintain our organ function until antibiotic clear the bacteria or virus. So because of that, we come across with concept of surviving sepsis. Surviving sepsis, what they did first is they change the definition time to time. It is helpful. How it is helpful? When you are doing the practice, you identified that previous definition cannot identify sepsis clearly, or there is no definitive mark between the different grade of sepsis. In that case, you can change the definition in order to identify large amount of sepsis patient correctly. Previous definition belong to sepsis 2. Up to now there are 3 sepsis update was came: sepsis 1, sepsis 2 and sepsis 3. Currently practice guidance belong to sepsis 3. According to sepsis 2, they define sepsis as number 1, systemic inflammatory response syndrome; number 2, sepsis; number 3, severe sepsis; number 4, multi-organ failure and septic shock. When coming to sepsis 3, they give only 2 definitions: number 1, sepsis; number 2, septic shock. It is very helpful to identify patient correctly. The severe sepsis patient, the markers also, the margin not that much clear. Systemic inflammatory response syndrome can occur without sepsis as well. Because of that, now we have only 2 definitions. We can easily identify who are the patient having sepsis, who are the patient having septic shock. And one of the most important thing of the changing of the definition frequently is the pathogen will know the current present definitions. So we can easily trap them. Still all the viruses and all bacteria think we are going to use these definitions, but currently we are using this definition. Okay, we'll see what is sepsis and septic shock. Sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. I will repeat it again. Sepsis is life-threatening organ dysfunction. Your organ should be dysfunction. organ dysfunction which should associated with life threatening. Due to host response to infection. That organ dysfunction not due to infection per se, it is due to host response. What are the organs which can be give rise to life-threatening complications? From top to bottom, your brain dysfunction can give rise to life-threatening complications. I will write down it here. This is definition I separately write. Life-threatening organ dysfunction caused by dysregulated host response to infection. We will see what are the organs which can give rise to life-threatening complications. Brain from top to bottom, lung, heart, liver, kidney, hematological system. Dysfunction of those organs can give rise to life-threatening condition in the patient. So, this is the definition of sepsis. We will see what is the definition of septic shock. Septic shock they define as subset of sepsis with circulatory, metabolic or cellular dysfunction associated with high mortality. They define it as subset of sepsis with circulatory, metabolic or cellular dysfunction associated with high mortality. That means your patient should have infection. Here infection plus organ dysfunction. Here infection plus circulatory impairment, your patient may need vasopressors. Infection plus vasopressors plus the cellular or metabolic dysfunction can be identified by checking the lactate level. High lactate level, infection, vasopressors plus high lactate level suggestive of septic shock. Infection plus organ dysfunction suggestive of sepsis. Number 2 is, according to surviving from sepsis management, rapid identification of patient with sepsis. How are you going to rapid identification of patient with sepsis? As I told earlier, life-threatening organ dysfunction caused by host response to infection. So, from this organ, which organ you can easily check by, or which organ you can clinically assess? Brain you can assess by assessing the GCS. Lung you can assess by assessing the respiratory rate easily. Cardiovascular system you can assess by using systolic blood pressure. You can quickly assess the organ failure assessment of your patient by checking these three stages. You can quickly assess organ failure assessment by using these 3 organs in order to rapid identify the sepsis. So this is called quick sequential organ failure assessment, also called QSOPA, including GCS, respiratory rate and systolic blood pressure. When your patient come into ETU or OPD setup, you have to rapidly assess those 3 if you are suspecting infection. If you are suspecting infection, patient came with cough, you have to assess GCS level, respiratory rate and systolic blood pressure to identify whether your patient having sepsis or not. For GCS less than 15, you can donate 1 mark. You donate 1 mark. Respiratory more than 22, 15, 1 mark. More than 22, 1 mark. Systolic blood pressure less than 100, 1 mark. If your patient having mark more than 2 or more marks, you should consider your patient having sepsis until proven otherwise. You have to manage according to sepsis guideline. Manage as sepsis. Suspecting infection with two of these category, two of these three you have to manage as sepsis. These are called quick sequential organ failure assessment. But this quick sequential organ failure assessment little bit differ when coming to pregnant patient. We'll see what is the difference. Their physiology little bit deranged. Because of that, this value are little bit different. GCS with the pregnancy, not going to change the GCS. GCS less than 15, 1 mark, and respiratory rate more than 26 here, and systolic blood pressure less than 90. Donate 1 mark, 1 mark, 1 mark. So, little bit different in the pregnant patient. Respiratory rate more than 26 and systolic blood pressure less than 90. Donate 1 mark. So, this is how you are going to identify when patient come into ETU and OPD setup quickly. We'll see how are you going to identify in patient who was there in the ward or ICU. Previously you check the patient, you couldn't find out any septic focus. But today you are thinking your patient is not good, maybe a part of sepsis. In that case, we'll see how are you going to assess whether your patient is truly having sepsis or not. Those are the organs which can affect due to host response against the infection. So, what I am going to check in your patient right now is, you don't need to do quick assessment because your patient now admitted and little bit stable. Because of that, you have to assess organ failure assessment, sequential organ failure assessment, but no need to do quick assessment. So, I will remove quick part, I will do SOFA assessment in your patient. For the GCS changes, you are going to donate 0 to 2 mark. Lung, here GCS. Lung, what I am going to check is, right now your patient admitted to a ward and even in ICU, maybe in ICU. So you can assess you can check the PF ratio. In the lung, you are going to check PF ratio. Cardiovascular system, previously you check the systolic blood pressure because in all the OPD and ETU, it may not be possible to measure the mean arterial pressure. Here you are going to measure mean arterial pressure. Liver, you are going to check bilirubin. Kidney, you are going to check serum creatinine or urine output. Hematological system, you are going to check platelet. For the PF changes, you can again donate 0 to 2. Mean arterial pressure changes less than 65 here. Here PF ratio less than 400. Here bilirubin more than 1.2. Here serum creatinine more than 1.2. Here platelet less than 150. According to degree of reduction of those organ function, you can donate 0 to 2 mark for each organ. 0 to 2 mark for each organ. So total score came 12 score. For a while we think yesterday your patient having a score of 4. Today score of 6. For a while we think 7. Changing of SOFA score more than 2 or more, highly suggestive of infection. Changing of SOFA score 2 or more, highly suggestive of infection. You have to find out the focus of infection rapidly and have to take appropriate action. So that is how we are going to identify the patient with sepsis. Okay, we will see how are you going to manage once you identify the patient. For the management of patient with sepsis, they introduce set of intervention which implement together, it will give better outcome rather than implement together. This is a pen. I am going to break it. I can easily break it, but when I combine 3 pen together, I can't break those things. I can separately bend and break pen separately, but when come as a bundle, it gives more strength than single one alone. KR bundle they define as simple set of intervention, group of intervention when implement together, give a better outcome rather than implement individually. And it should be easily auditable, and it should be widely accepted as good practice. Once you do the KR bundle for your patient, your consultant should say good boy. So that means it should be KR bundle. When coming to sepsis KR bundle, previous guideline what they says is 1 hour bundle and 3 hour bundle. We have changed that 1 hour and 3 hour bundle together now. Only 1 hour bundle available. Why that change we done? There is a time delay between the 1 hour and 3 hour bundle. So until 3 hours, some doctors are not going to do anything because 3 hour bundle have to start after 3 hours. They are waiting until 2 hours and 59 minutes right now. I have to wait another 1 minute to start 3 hour bundle. Tuck, 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 tongue, and 3 hour bundle going to start like that. So because of that, some patient may need inotrope at present, but when coming to 1 hour and 3 hour bundle, you have to do initial fluid resuscitation for 3 hours, then have to start inotrope if necessary. So that is not a good practice. Because of that, combination of both 1 hour and 3 hour bundle, right now they are practicing 1 hour bundle. We will see what are the components of 1 hour bundle. Number 1 is when you are highly suspecting patient with sepsis or septic shock, you have to take blood culture. Number 1, take blood culture and have to start broad spectrum antibiotic. How much of blood cultures are you going to take? At least 2 blood cultures you have to take. 1 for aerobic, 1 for anaerobic, and if possible for antifungal culture as well. And then you have to start broad spectrum antibiotic to cover all the possible organism. What do you think if you are unable to take blood culture? It is one of the common thing happen when a collapse. Somehow you insert IV cannula, but you couldn't take antibiotic. Sorry, you couldn't give antibiotic. Then what are you going to do? In that case, you have to give antibiotic even though blood culture is not available. Why they ask to take blood culture so and so? Because your broad spectrum antibiotic can kill bacteria, but it is better to give narrow spectrum antibiotic against the present organism, because in that case antibiotic resistance will be minimal. So if you are unable to take blood culture, again you have to start broad spectrum antibiotic. Sometimes this one will happen when we start antibiotic, following day patient look like completely normal. You are also suppressing, your consultant also suppressing. Why you start KR bundle for this patient? Why you do fluid resuscitation? Why you do take blood culture? Like that, several questions asked. Then what are you going to tell? Sometimes even with the first antibiotic shot, your blood can be sterile even after 5 to 10 minutes. So you can be totally normal in the following day. Or sometimes you misdiagnose sepsis. How are you going to differentiate both two? In that case, you have to do procalcitonin level. If procalcitonin is high, highly suspecting sepsis. If procalcitonin is low, you can safely stop the antibiotic in that kind of case. So procalcitonin, one of the inflammatory acute phase inflammatory markers. There are other non-specific markers also. They are CRP, and ferritin. Those are not that much specific for sepsis. CRP can also rising in patient with several kind of inflammation, not the infection. Even with the myocardial infarction, CRP can go up. So you have to start broad spectrum antibiotic. Number 2. You have to measure the serum lactate level. Number 2, measure serum lactate level. Lactate is one of the very important marker of tissue hypoperfusion and one of the important marker of mortality. How lactate produced? We will see. Your glycolysis is started, glucose convert into pyruvate. You produce one NADH and ATP. Pyruvate enter into the citric acid cycle or Krebs cycle. You made several NADH. That NADH have to go through electron transfer chain by the help of oxygen. They convert NADH to NAD. They produce ATP. Large amount of ATP produced from electron transfer chain. This NAD recycle into Krebs cycle and Krebs cycle function can be maintained. Once your oxygen level goes down, you can't convert NADH to NAD furthermore. So less NAD available there. Because of that, you can't continue your Krebs cycle. Krebs cycle is stopped. Because of that, your pyruvate cannot enter into Krebs cycle. Because of that, your glycolysis is also now about to end. Now lactate comes, says, no, we don't do that one. Somehow we want to survive. I will help you. What lactate does is, not the lactate, pyruvate convert into lactate. That conversion process of the pyruvate to lactate utilize one NADH molecule, NADH molecule and produce NAD molecule. So we can use this NADH molecule here and again you can reproduce NADH. That NADH can utilize here for continuation of the glycolysis. So you can continue glycolysis with the help of NADH and you can create lactate. So lactate is one of the marker of tissue hypoperfusion. You can identify from this graph. So lactate is one of the important marker of tissue hypoperfusion here. We will see how much of lactate elevation was there in patient with sepsis. If you read literature and articles several times, you may have come across some book says lactate 4, some book says lactate 2. I prefer to have lactate 2 because lactate 2 associated with roughly about 4% mortality, lactate 4 roughly about 28% mortality. Different studies says different number, but approximately lactate 2 associated with 4% of mortality, lactate 4 is associated with 28% of mortality. Once you found to have high amount of lactate, you have to repeat lactate level after fluid resuscitation and starting of vasopressors. After fluid resuscitation, you have to remeasure the lactate level usually 2 to 3 hours later. So one of the thing is measure the serum lactate level. You have to remeasure it after 2 to 3 hours. Third one, you have to do fluid resuscitation in your patient. Why your patient need fluid resuscitation? Because of the sepsis and cytokine, your vessel become vasoplegic and increase the capacity. Because of that vasodilatation, large amount of fluid remain in the vascular compartment. Because of that, you may feel relative hypovolemia because of that vasodilatation. To overcome that, you have to give large amount of fluid. In addition to that, capillary leaking also increase with the sepsis. So fluid leaking into the interstitial space and third space also will be high. So we have to do aggressive fluid resuscitation. What they say is 30 ml per kg fluid resuscitation should done in all patients, all adult patients. Are you going to give 30 ml per kg fluid bolus in patient with congestive cardiac failure or end stage renal failure who are waiting or who are undergone renal replacement therapy? Answer is, we'll see. So for the fluid resuscitation, they asked you 30 ml per kg. If your patient is not on oxygen, no congestive cardiac failure, no end stage renal failure, you can safely give 30 ml per kg fluid bolus. You can safely give 30 ml per kg fluid bolus. If your patient depend on oxygen or you suspecting lung injury in your patient with part of ARDS, you can give 30 ml fluid bolus with frequent monitoring. That means after 10 ml per kg, you have to assess the saturation and adequacy of fluid resuscitation. If patient drop in saturation, you have to cut down the fluid. Somehow you can give 30 ml if patient does not deteriorate. Or you can intubate if necessary. If your patient having acute lung injury and high flow oxygen, you can intubate and you can give 30 ml per kg fluid bolus. Once you intubate the patient, you create positive pressure in the alveoli. Because of that, pulmonary edema is less likely with intubated, positive pressure ventilated patient. So you can safely give 30 ml in that case. In patient with congestive cardiac failure or end stage renal failure, you can give 30 ml per kg fluid bolus, but you have to frequently assess, like 10 ml per kg fluid bolus and reassess, 10 ml per kg bolus, reassess like that. So that is how we are going to give the fluid. Which kind of fluid are you going to select? There are available fluid type: colloid, crystalloid, sometimes that come into separate category. Which kind of fluid are you going to choose? I preferred, and guideline also preferred, crystalloid. There are several kinds of crystalloid available. Which crystalloid are you going to choose? Number 1, normal saline. Number 2, Hartmann. Number 3, plasmolite. Number 4, normal plasma light. Normal saline, Hartmann, plasma light and normal sol. What they said is frequently available to is normal saline and Hartmann. There is no difference between the normal saline and Hartmann. But I preferred Hartmann solution when we doing large amount of fluid resuscitation because of the fear of normal saline associated hyperchloremic metabolic acidosis according to Stewart equation. Stewart acid-base analysis method. Okay, I preferred normal Hartmann for fluid resuscitation in our patient. If your patient need large amount, what do you think about subsequent fluid? You resuscitate with 30 ml per kg fluid bolus, still you feel your patient is underfilled. In that case, you have to do static and dynamic fluid assessment. And to decide whether your patient need further fluid or not. For the static fluid assessment, you can use the blood pressure, BP, pulse rate, skin turgor, urine output, thirst, CRFT, capillary refilling time. Like thing you can use for static fluid assessment. For dynamic fluid CVP also here. For the dynamic fluid assessment, you can use pulse pressure variation, stroke volume variation, SVC collapsibility, IVC distensibility, left ventricular outflow tract time velocity index, fluid challenge, conventional fluid challenge or mini fluid challenge, passive leg raising test. Those are the tests available for dynamic fluid assessment. You can do one of those things and you can assess the fluid requirement of your patient, whether your patient is still underfilled or overfilled. According to that, you can decide to give further fluid. You give large amount of fluid, now you are afraid to give even fluid after, because you already given substantial amount of fluid. In that case, you can consider albumin. 4% albumin or 20% albumin. 4% albumin approximately containing 25 gram per deciliter albumin, which is nearly close to the plasma albumin value. Because of that, albumin value in the plasma is a little bit higher than this one, but for a while we think nearly close. Because of that, if you are going to give 100 ml of 4% albumin, it will remaining in the vascular compartment. The vascular filling is 100 ml. But here, when coming to 20%, it is approximately 4 times of that. That means nearly 80 to 100. Sorry, nearly about 80. 80 gram per deciliter is there. Because of that, it can expand. If you are going to give 100 ml of 20% albumin, it can drag interstitial fluid into the vascular compartment. It can expand approximately 300 to 400 plasma volume. 300 to 400 ml plasma volume. Okay, you can give albumin. What do you think about? Can you give hetastarch to your patient? Yes, you can give hetastarch to patient, but following day you have to absent because your consultant will blame on you. It is one of the contraindication. It found to have increased the renal failure and it interfered a little bit with cross-matching process as well. So, number third is fluid resuscitation. It should be 30 ml per kg at least. Number 4 is starting vasopressors. The first choice of vasopressors is noradrenaline. As I already told, the hypotension mainly the sepsis due to vasodilatation, the hyperdynamic circulation. You can see the bounding pulse in patient with sepsis most of the time, but it can be non-bounding in patient with sepsis when it become when sepsis depress your heart, you can develop cardiomyopathy, also called Takasubo cardiomyopathy. In that case, you may have low ejection fraction with non-bounding pulse. So, in patient with sepsis, because of the vasodilatation, the first choice of vasopressor is noradrenaline. First choice noradrenaline, second choice vasopressin. Third choice adrenaline. Fourth choice phenylephrine. In patient, you can first of all you can start noradrenaline with the maximum dose. If you feel you can't achieve target main arterial pressure of 65, you can add vasopressin 0.03, or then you can add adrenaline, you can add phenylephrine. Somehow you achieve adequate blood pressure with noradrenaline. But you think you given little bit of higher side noradrenaline. Because of that, you want to cut down the noradrenaline level. For that, you can add vasopressin. To cut down the noradrenaline, you can start add noradrenaline. In spite of large number of fluid resuscitation, this much of fluid resuscitation and iron drop, if your patient is still having low blood pressure, you can consider hydrocortisone. You can consider hydrocortisone. How much? 200 milligram per day. You can give a single dose or divided doses. You know, the glucocorticoid help to adrenaline to act well. That's called permissive action. To function that proper adrenaline function, you need little bit amount of glucocorticoid. Because of that, you can give hydrocortisone. With that, you can see the improvement. And the source control. Number 5, source control. Previous guideline says source control should be delayed. Initially, you should do minimal invasive surgery without that much of disruption. But currently, what they say is source control you should done when how it logistically and practically possible. When it is logistically and physiologically possible, you have to do proper surgery. Source control. You should not delay source control as previous. Okay, those are the things come in the care bundle. Blood culture and broad spectrum antibiotic, measure serum lactate level and remeasure after 2 to 3 hours. Fluid resuscitation, you know how to do it right now. Vasopressors, you know noradrenaline, vasopressin, adrenaline and phenylephrine. Sometime you may have to start dopamine in the children or patient with bradycardia. And you have to start hydrocortisone sometime if patient is not responding to fluid resuscitation and vasopressor therapy. You may have to do surge control when patient medically and logistically possible time. Okay, we'll see what are the supportive measures they invent in surviving sepsis. What are the supportive measures? If you think your patient need ventilation for the fluid resuscitation or due to cytokine induced lung damage or ARDS, in that case you have to do lung protective ventilation. You already know tidal volume 6 ml per kg for ideal body weight. Plateau pressure should be less than 30 cm H2O. In addition to that, you can consider prone ventilation if PF ratio less than 150, or you can consider high frequency oscillatory ventilation, or you can consider non-invasive ventilation. But they didn't comment about the non-invasive ventilation, whether it is good for patient with sepsis or not. So up to now you can practice lung protective ventilation with prone ventilation and high frequency oscillatory ventilation. So second thing is, if you found a patient with HB less than 7, you can transfuse blood. HB less than 7, you can transfuse blood. Or HB more than 7, but your patient having ischemic changes in the ECG or continuous bleeding, you can consider blood transfusion. If your patient having HB less than 7, definitely need blood transfusion. HB more than 7 may need blood transfusion if your patient having ischemia or bleeding. So third thing, if your patient found to have kidney damage with high serum creatinine, you can consider renal replacement therapy. Dialysis or hemofiltration you can consider. Enteral nutrition is preferred than parenteral nutrition. You have to practice, when possible, you have to practice enteral nutrition. You have to practice DVT prophylaxis. There are two major group of DVT prophylaxis, pharmacological and non-pharmacological. If there is no contraindication for pharmacological prophylaxis, you have to do pharmacological prophylaxis plus mechanical prophylaxis. That means your hematological system is not going to upset, or your patient is not having coagulopathy. You have to start pharmacological DVT prophylaxis method. Last one, stress ulcer prophylaxis. You have to start stress ulcer prophylaxis when necessary. The one after the last one is glycemic control. You have to maintain the glycemic level between 110 to 180 milligram per deciliter. If you found to have high blood sugar twice, more than 180 two times, you have to start insulin infusion. Variable insulin infusion you have to start. Once you start insulin infusion, you have to measure the blood sugar 1 to 2 hours time until stabilize. Then you can do blood sugar every 4 hours. Okay. That's all regarding the sepsis management. Thank you.